When you hear hoofbeats, what's the first thing that you think of? As healthcare professionals, you're taught to think of horses, not zebras, when you hear hoofbeats. In other words, to consider the more common diagnosis before a rare one. But sometimes those hoofbeats just might be the sounds of zebras. As we'll see this evening, a combination of two common signs may mean that your pediatric patient has a rare genetic disorder. Good evening, I'm Patricia Stark. Welcome to Is There a Zebra in Your Practice? High-definition broadcast event sponsored by Shire. Tonight, we'll uncover the mystery of this rare genetic disorder. I'm here with two experts who are going to tell us what ENTs, pediatricians, and other healthcare providers need to know to identify patients with this disorder so that a diagnosis can be obtained more quickly. We are pleased to be here tonight with a leading otolaryngologist, Dr. David W. Moulter. Dr. Moulter is professor of otolaryngology at Washington University School of Medicine at St. Louis Children's Hospital. Welcome.
Thank you.
And our other expert tonight is a leading geneticist and pediatrician, Dr. Barbara K. Burton, who is professor of pediatrics at Feinberg School of Medicine, Northwestern University, and director of clinical practice in the Division of Genetics, Birth Defects, and Metabolism at Ann and Robert H. Lurie Children's Hospital of Chicago. Welcome.
It's great to be here.
Now, both Dr. Moulter and Dr. Burton are sponsored by Shire this evening. We're here to discuss a rare but distinctive disorder that many of you who are pediatricians and ENTs may encounter in your practice. Our experts are going to tell us what you need to know in order to identify patients with this disorder so that they can be diagnosed more quickly. Dr. Burton, why is it so important for our audience to learn about this disorder?
Well, Patricia, the diagnosis of this mystery disorder can be quite elusive. The individual signs and symptoms are not specific to this condition, and each patient presents with a unique constellation of manifestations. Therefore, in the absence of a family history, the delay between manifestations and diagnosis can be significant. In fact, there may be a delay of several years between the onset of signs and symptoms and diagnosis. This applies particularly to patients with the attenuated phenotype of the disease, in whom manifestations may be subtle. A common pitfall for clinicians is failing to link the numerous and seemingly unrelated signs and symptoms into a single condition.
Dr. Moulter, would you agree with Dr. Burton's assessment?
Absolutely. It's certainly the path to diagnosis of these patients can be difficult, and it may include a lot of physician visits over a number of years before the correct diagnosis is made. For example, let me tell you about James. As an infant, James appeared to be a normal, healthy child. He developed several colds and ear infections, but as these are common childhood ailments, his pediatrician was not concerned. Around this time, James also developed an inguinal hernia. As months passed, James' infections became more frequent and led to many urgent care visits. His appearance also began to change from that of a healthy, chubby baby to one with a distended abdomen and increasingly gaunt extremities. He continued to struggle with poor health. His mother started to become frustrated by frequent illnesses, lack of consistent care, and unanswered questions. In fact, James was referred to an otolaryngologist. The ENT recommended inserting tubes into James's ears to improve his drainage. During the history and physical exam, the physician noted multiple ear infections, inguinal hernia, a likely need for adenoidectomy or adenotonsillectomy, and coarse facial features. The ENT began to suspect there was an underlying issue behind James' symptoms. He thought that James might have a genetic storage disorder and asked the geneticist to attend his next appointment. The blood test confirmed that James had Hunter's syndrome, also known as mucopolysaccharidosis type 2, or MPS II, a progressive and debilitating disorder that interferes with the body's ability to break down and recycle mucopolysaccharides, which then accumulate and damage the respiratory, central nervous system, joints, liver, and spleen.
So, Dr. Moulter, what would you say was the key factor in making this diagnosis? I mean, what was really the tip-off here?
Well, if you have a pediatric patient needing an adenoidectomy or adenotonsillectomy with a history of inguinal hernia, In the absence of prematurity, then you should consider Hunter's syndrome. Hunter's syndrome is a rare condition. The incidence is only 1 in 162,000 live births. But if you see that rare but characteristic combination of adenoidectomy or adenotonsillectomy and inguinal hernia, the odds of Hunter's syndrome, or MPS II, could be as high as 1 in 55. So this combination of symptoms should really make you think twice.
Now, Dr. Burton, as our geneticist on the panel, can you give us a general sense of MPS disorders?
Certainly, Patricia. MPS, which again stands for mucopolysaccharidosis, refers to a family of rare genetic disorders caused by deficiency of the lysosomal enzymes that are required to degrade or break down mucopolysaccharides, now referred to as glycosaminoglycans, also known as GAGs. As you may know, GAGs are long, unbranched, polymeric carbohydrate molecules that serve a number of important functions that we won't have the time to discuss tonight. In MPS disorders, undegraded GAGs accumulate in lysosomes, resulting in various types of cell, tissue, and organ dysfunction. There's a wide spectrum of clinical severity in MPS. A chronic and progressive course of the disorder may include profound cognitive impairment in some forms of MPS, including the severe form of MPS II or Hunter syndrome. And from a diagnostic perspective, it's key to be aware that there are enzyme assays that are available to allow the clinician to confirm a suspected diagnosis of MPS.
And what about the signs and symptoms? Is there a typical presentation across MPS types?
In general, MPS disorders affect a number of different organ systems. While there are commonalities of signs and symptoms across MPS types, signs and symptoms can vary greatly from patient to patient, even within a given MPS type. So as clinicians, we need to look for those unusual clusters of common signs and symptoms or individual occurrences of unusual symptoms that are key to making a diagnosis of any given type of MPS.
And in Hunter syndrome in particular, Dr. Burton, can you situate it within the broader spectrum of the MPS disorders?
Hunter syndrome is an inherited X-linked recessive disease that affects males almost exclusively. Although it's rare, a few cases of girls with MPS II have been reported in the literature. In these cases, the disease phenotype results from complete inactivation of the non-mutant paternal X chromosome. Female carriers of the Hunter syndrome gene are typically asymptomatic heterozygous carriers of the condition. Hunter syndrome is named after Charles Hunter, who first described the syndrome in 1917. The syndrome is caused by a deficiency, or in some cases a complete absence, of the lysosomal enzyme iduronate 2-sulfatase, or I2S for short. I2S is required for the breakdown of GAGs, and so a deficiency or absence of I2S leads to a lysosomal accumulation of GAGs in cells, tissues, and organs throughout the body. As Dr. Moulter mentioned a moment ago, Hunter syndrome is a rare disease, but nevertheless, it's a very serious disease. It causes significant morbidity and substantial early mortality.
Dr. Burton, earlier in the program, you mentioned attenuated phenotype of Hunter syndrome. Can you elaborate on what that is?
Certainly, Patricia. Hunter syndrome is always a serious condition. However, it presents as a continuum of manifestations and complications ranging from attenuated to severe disease. The severe phenotype is more common, and the natural history for severe disease is relatively predictable. In severe disease, there are both somatic manifestations and cognitive involvement, and patients typically die in their mid-teens. In patients with the more attenuated form of the disease, there is considerable variability in the natural history of disease progression. In these patients, the disease has a more chronic and protracted course, and there is no cognitive impairment.
I think at this point it would be really helpful for you to give us an overview of the general features of Hunter syndrome.
Of course, Hunter syndrome is generally not evident at birth, but clinical features are typically observed within the first 2 years of life. Initially heterogeneous, the disease then progresses and eventually leads to a significant loss of mobility and functional independence, as nearly all organs are affected. Skeletal abnormalities due to defective bone formation, such as bone dysplasia or dysostosis, often cause a characteristic posture of hunched shoulders when the child walks. Patients also tend to walk with a stiff gait. Other skeletal features include a large skull and short neck. Ultimately, patients are short in stature and typically have hernias and an enlarged liver and spleen. Both hepatosplenomegaly and umbilical hernia can contribute to causing a protuberant or bulging abdomen. Skin lesions are also quite common. Patients with Hunter syndrome typically have flesh-colored papules, which are often referred to as pebbles, overlying their shoulder blades that develop in the 2nd or 3rd year of life and then progress slowly.
And how does Hunter syndrome affect different organ systems?
The accumulation of GAGs results in pathology throughout a range of organ systems, including the skin, as I mentioned, central nervous system, eyes, and overall physical appearance. So, for example, we may see the pebble skin lesions, hydrocephalus, glaucoma, or coarse facial features in some or many patients. We may also see pathology in the skeletal, respiratory, cardiac, gastrointestinal, and peripheral nervous systems, as you see on the slide. It's important to note, however, that each patient exhibits a unique set of manifestations and that it is the unusual clusters of otherwise common signs and symptoms or the individual occurrence of unusual symptoms that are key to making a diagnosis.
And what should lead clinicians to suspect that their pediatric patient has Hunter syndrome?
There are certain signs and symptoms, Patricia, that should prompt clinical suspicion of Hunter syndrome. These are listed for you here on this slide and include enlargement of the liver and spleen, which can result in abdominal distension, unexplained watery diarrhea, particularly in patients who have neurologic involvement, valvular heart disease, which can result in a murmur and eventually leads to right and left ventricular hypertrophy and heart failure, progressive airway obstruction, neurologic manifestations, which may include cognitive impairment, delayed developmental milestones, aggressive or disruptive behavior, and hydrocephalus. We should note again, however, that these types of manifestations can be present in many patients, but CNS involvement is limited to patients with a severe phenotype, so there are some patients who have none of these. Carpal tunnel syndrome is something that's very unusual in young children and should always increase your suspicion of an MPS disorder, including Hunter syndrome. Progressive hearing loss is also another important finding. Patients with Hunter syndrome can present with any combination of these signs and symptoms, and early recognition requires that you pay attention to these factors, many of which overlap with common childhood complaints. So again, the bottom line is clinical suspicion should be triggered by particular clusters of signs and symptoms that are unlikely to have appeared together in an otherwise normal, unaffected child, but often occur together in a child with Hunter syndrome. Now, different symptoms typically appear at different ages, ranging from birth to 7 years. And since routine newborn screening is not yet available for MPS II, it's especially critical that ENTs, pediatricians, family practice physicians, and pediatric specialists be aware of these early symptoms of Hunter syndrome for early identification, referral, and diagnosis in order to help optimize patient outcomes.
Dr. Moulter, is there anything that you'd like to add here?
Well, yes, as a matter of fact, I wanted to point out that as you can see on the slide that Dr. Burton is discussing, the earliest symptoms to appear are ear and respiratory infections alongside with the abdominal hernia. So the pediatric ENT may well be among the first clinicians to see these patients in their clinical practice. And that just underscores what Dr. Burton was saying about the importance of pediatric ENTs in particular of being aware of these symptoms. In the patients that we see early in their course of disease, if we know what to look for, and if we are primed, so to speak, to be suspicious of these clusters of symptoms, then young patients can be diagnosed and receive appropriate care.
That's a really important point that you just made, David. Thanks for bringing it up. And I think it's an excellent segue to the next 2 slides I want to show the audience. In these photos, you see key somatic features of Hunter syndrome, such as joint stiffness and contractures, hands that appear claw-like, and a short trunk and neck. While on physical examination, we might note common presenting features such as a heart murmur, hepatosplenomegaly, and abdominal distension. In the photo on the slide, you see the characteristic abdominal distension suggestive of the presence of hepatosplenomegaly.
All right, well, if I may interrupt for just one moment, Dr. Burton and Dr. Moulter, we would like you all to meet very special guests who know very well the long and frustrating course that leads to a diagnosis. Please join me in welcoming Jackson and his mother, Carrie.
Hi, thanks for having us.
Thank you both for being here. So, Carrie, can you tell us a little bit about Jackson's history?
Sure, certainly. My name is Carrie, and for 5 years, my wife Melissa and I had used an anonymous donor to try to start a family. Once I finally became pregnant, we quickly found out that we were having twins, and Jackson and his sister Sydney. So my pregnancy was considered a high-risk pregnancy, being that it was twins. About halfway through, we learned that Jackson was showing signs of mild ventricular megalomy, which the doctors had told us was found mostly in boys with Down syndrome. We were determined to have these babies, and we opted not to do any further testing. Jackson and Sydney were delivered by emergency C-section a few weeks early, but they were both healthy weights, and they appeared to be fine. But within minutes, Jackson had difficulty breathing, and he was taken down to the NICU, where he was treated for pneumothorax. Jackson was cleared for discharge 22 days later, and our twins were reunited at home. But as time went on, we noticed that he was developing very differently. Jackson had a large distended belly, a very large head. He had a small stature, and he had some chronic constipation, which we later learned were due to the mild enlargement of his liver and spleen. Sydney was walking at about 9 months, and Jackson didn't start till 12 months. Jackson had done something we called the commando crawl, and we also noticed that his skin was extremely taut. The pediatricians told us he'll be fine, don't worry about it. Boys develop a little bit slower than girls, and we had the twin factor, having a boy and a girl right there. They said that his Buddha belly was just baby fat, and that we knew that wasn't right. When Jackson was 2, we went to a developmental pediatrician, and she said she could tell something was wrong, but she really couldn't put her finger on it. We were given the diagnosis of PDD-NOS, pervasive developmental disorder, a condition along the autism spectrum. Melissa and I both felt that he did not have autism. We just knew it. Jackson was social. He made eye contact. He wanted to talk. He was making sounds, but the words just weren't coming out. When he was 3, we were finally put in touch with a geneticist, and at that appointment, within 2 minutes, she examined him and noticed that he had an unresolved inguinal hernia, which was part of the underlying condition, and we didn't know it at the time. She gave us an urgent next day referral to a metabolism specialist. Upon entering that appointment, Jackson was in the stroller, and within 2 minutes, she said, "I think I know what your son has. I believe he has something called Hunter syndrome." Looking back on it now, we really figure you could see all of the characteristics and symptoms of the Hunter boys, and Jackson fit those criteria. Jackson also had characteristic dental problems, including peg-shaped teeth, lack of enamel was definitely there, and it must have been extremely painful for him for the first couple of months, and that's why he wasn't speaking. But now looking back, the problems that he did have over time were preventing him from talking. You wouldn't see it right now, but normally he is talking up a storm and he doesn't stop talking. So, and to look at him, you wouldn't necessarily think anything's wrong with him.
Not at all.
He is definitely a bright young man, but he is cognitively about 6 months behind his peers. Okay. And we're just happy he's here.
Oh, absolutely. Oh, well, thank you so much for sharing that story. It's very moving. It clearly illustrates the long and frustrating path to diagnosis that is so common for patients with Hunter syndrome.
Hey, Jackson, it's great to see you. Thanks for coming in. How old are you now?
I am 8.
And what grade are you in school?
I'm in 3rd grade.
All right.
Awesome. Dr. Burton and Dr. Moulter, do you think that this history is classic for patients with Hunter syndrome?
Yes, it is. And Jackson's story emphasizes that there's a great range of manifestations in the cases we see. In attenuated cases, there is little to see at birth. And typically, there may be an initial presentation of hernia or frequent ear and respiratory infections, which then progress to greater disability as the child ages. In others, there's a more obvious presentation and progression, including mental impairment early on. So the presentation varies from individual to individual, and as we mentioned earlier, clinicians need to be on the lookout for clusters of symptoms that suggest an underlying cause, or for individual occurrences of unusual symptoms. I think here we have a case perhaps that illustrates the latter. Jackson did have an inguinal hernia, but he did not have a history of adenoidectomy or adenotonsillectomy, as we had talked about earlier.
Exactly, and you know, we often talk about how frequent ear infections are a typical sign of Hunter syndrome boys, but Jackson was unique in that he only had 2 ear infections by the time he was 8. Many of the other families in our MPS community, they are having 2 or 3 sets of tubes early on by a very young age. Jackson, I would say, is not characteristic of those symptoms, but he just manifests his Hunter syndrome a little bit differently.
Yeah, thank you. This is an excellent point that underscores the variability in the presentation. Every patient is different, and above all, it's imperative to look at the whole patient.
And obviously, he had many of the other common findings, the distended abdomen, enlargement of the liver and spleen,
Correct.
the hernia, and so forth. So there's no one thing that every patient absolutely has to have.
I would agree.
Well, Carrie and Jackson, thank you so much for sharing your story. And Jackson, you are an awesome little boy, and hanging out with you backstage, you've got great manners too. So thank you so much.
Bye.
Great
Bye,
help.
Jackson.
Bye, Jackson.
Bye. Okay, Dr. Moulter, our time is growing a little short here, so why don't we turn to some of the diagnostic features of Hunter syndrome, especially for the keys for ENTs.
Absolutely. ENTs are likely to see a range of symptoms affecting ears, nose, throat, and teeth. Frequent middle ear infections, hearing loss, either sensorineural or conductive, or a mixed loss, recurring respiratory infections, chronic runny nose, upper airway problems, and sleep apnea. Lung and airway problems are of particular concern because they can lead to an increased risk during anesthesia or intubation procedures. We often see enlarged tongue, tonsils, adenoids, tracheomalacia, and irregular teeth that are often peg-shaped. In addition to the ear, nose, and throat, the oral cavity, we may see developmental delays, speech delays, macrocephaly, and a characteristic coarsening of the facial features, the hair and the eyebrows that are likewise thick and coarse. These patients may present with a high prominent forehead or brow, a flattened nose, thick lips, and enlarged tongue. As the disease progresses, we may see the tongue begin to protrude more in an effort to ease breathing, and that may sometimes be associated with the drooling that we often observe. In early childhood, children with Hunter's syndrome often grow faster than their peers, with growth slowing at approximately age 3 or 4 years of age.
Okay, thank you, Dr. Malter. Well, as we draw near to the end of our program tonight, I would like to ask both of our expert panelists to talk about what clinicians should do once they've encountered these rare clusters of common symptoms and have, in fact, come to suspect a diagnosis of Hunter syndrome. So what's the next step?
Well, if you suspect MPS, you need to refer to a geneticist. Keep in mind that as an ENT or a pediatrician or family practice physician or a pediatric specialist, you may be one of the first medical professionals in this patient's young life, if not the first, to suspect Hunter syndrome. The only way to get there, however, is to consider the whole patient, including aspects of the patient's medical history, physical exam, or other clues to you that may be beyond your formal area of medical expertise. Remember that it's an unusual cluster of common signs and symptoms or individual occurrences of unusual symptoms that prompts a suspicion for MPS.
And Dr. Burton, is there anything you'd like to add here?
I'd just like to add that if you do suspect Hunter syndrome or any of the other forms of MPS, then I agree 100% with Dr. Malter that the first thing to do is to make a referral to a geneticist for definitive diagnosis and appropriate care and counseling.
Could you go a little bit more into this referral process and then what comes next?
Sure, absolutely. If Hunter syndrome is suspected, the first thing to do is to contact a specialist center with a medical geneticist to discuss your suspicion. The first test commonly performed is a urine screening test for MPS disorders. A negative result to this screening test, however, does not completely exclude an MPS II diagnosis, since false negatives may occur. Definitive diagnosis is achieved by measuring the I2S enzyme activity in white blood cells, cultured skin fibroblasts, or in serum. Now, while testing for I2S enzyme activity can provide a definitive diagnosis of Hunter syndrome, it's important to note that the absolute level of enzyme activity does not predict the severity of the phenotype on the clinical spectrum. Additional diagnostic tests that might be performed include bone radiography, which may reveal any of the characteristic bone changes that are present. Prenatal diagnosis for Hunter syndrome can be done using amniotic fluid or chorionic villus biopsies in the case of unborn children with a family history of Hunter syndrome, where the mother is known to be a carrier. Shire can serve as a useful source if you need more information about diagnostic testing.
Well, that's a great tip, Dr. Burton. Where else can clinicians go to find more information about testing and referrals, with their patients with Hunter syndrome?
Well, in fact, there are a variety of resources available. General disease awareness information can be found on the website www.hunterpatients.com. To learn about testing for Hunter syndrome, clinicians can go online to www.genetest.org. There are also a number of ways to find medical geneticists and genetic counselors in your area, including the World Health Organization Genomic Resource Center, the American College of Medical Genetics, the National Society of Genetic Counselors, and the University of Kansas Directory of Genetic Professional Societies and Organizations.
And Dr. Burton, it would be terrific if you could summarize, what are the key points to tonight's discussion, like the 2 or 3 main takeaways that you'd like our audience to remember?
Sure, Patricia. I would just reiterate something that Dr. Moulter said earlier in the evening. Hunter syndrome is rare overall, with an incidence of only 1 in 162,000 live births. But if you see adenoidectomy or adenotonsillectomy due to chronic infection and inguinal hernia or a history of inguinal hernia repair in a male less than 6 years of age, you should think twice. This could be MPS II. So again, if your pediatric patient undergoes or needs adenoidectomy or adenotonsillectomy and has a history of inguinal hernia in the absence of prematurity, then you should consider Hunter syndrome. This rare combination of symptoms really should make you think twice. The hoofbeats you hear just might be a zebra.
Thank you, Dr. Burton. We hope that you have enjoyed tonight's broadcast. It's been our pleasure to provide you with this educational program. On behalf of Shire, Dr. Moulter, Dr. Burton, Carrie, and Jackson, have a great night.